Bismillahirrahmanirrahim. Today's lecture is about the descending tracts, physiology of motor track. Descending motor system is divided into major subgroup pyramidal tracts and extrapyramidal tracts. The pyramidal tracts are further subdivided into cortico-spinal tract and corticobulbar tract. The extrapyramidal tracts are subdivided into rubrospinal tract, tacticospinal tract, vestibulospinal tract, reticulospinal tract, and olivospinal tract. Physiology of motor tract. In order to initiate any type of voluntary movements, there are two levels of neurons that the body uses. They are upper motor neurons. They are the motor neurons whose cell bodies lie in the motor cortex or brainstem, and they activate the lower motor neurons. Lower motor neuron. These are the motor neurons of the spinal cord and brainstem. Motor nuclei of the cranial nerve innervate the skeletal muscle directly. The descending tracts. The descending tracts are pathway by which motor signals are sent from the brain to the lower motor neuron. The lower motor neuron then directly innervates muscle to produce movements. All of the neurons in the descending tracts are upper motor neuron, with their cell body being located in the cerebral cortex or brainstem and their axons remaining in the central nervous system. Descending tract can be divided into pyramidal tract and the extrapyramidal tract. Let me here clear the upper motor neuron and the lower motor neuron. The upper motor neuron originates from the cerebral cortex and they descend through the brainstem and spinal cord and end in the anterior horn of gray matter of the spinal cord. So this is the upper limit of the upper motor neuron. Originate from the cerebral cortex and terminate at the anterior horn of gray matter of the spinal cord, from where lower motor neuron originate and then innervate the muscles. So motor cortex of the brain, here the motor neuron originate, upper motor neuron then end on the lower motor neuron, and the lower motor neuron innervate the muscles. Pyramidal tracts. The pyramidal tract derive their name from the medullary pyramid of the medulla oblongata, which they pass through. These pathways are responsible for the voluntary control of musculature of body and pace. Functionally, these tracts can be subdivided into two. Corticospinal tract supply the muscle of the body. Corticobulbar tract supply the musculature of the head and neck. Corticospinal tract. The corticospinal tract is a white matter motor pathway starting at the cerebral cortex. They terminate on the lower motor neuron and anterior horn in the spinal cord, controlling movement of the limb and trunks. They originate here in the cortex and then terminate at the anterior horn of the gray matter of the spinal cord and control the movements of the limb and trunks. The corticospinal tract originates in several parts of the brain, including not just the motor area but also the primary somatosensory cortex and premotor area. Most of the neurons originate in the primary motor cortex, premotor cortex, and supplementary motor cortex. This area is the primary motor cortex area. In front of it is the premotor cortex, and above this is the supplementary motor area. About 30% of the corticospinal nerves originate in the primary motor cortex, 30% more in the premotor cortex and supplementary motor area, with the remaining 40% distributed between the somatosensory cortex, the parietal lobe, and the cingulate gyrus. Corticospinal tract. After originating from the cortex, the neuron converge and descend through the internal capsule, a white matter pathway located between the thalamus and the basal ganglia. You can see that these fibers originate from the cortex. They pass through the internal capsule. The internal capsule is located between the thalamus and the basal ganglia After the internal capsule, the neuron passes through the crus cerebri of the midbrain, pons, and into the medulla. This is the crus cerebri. Here you can see that the cerebellum is connected with the midbrain by 3 peduncles. Crus means peduncles. So these fiber then pass through these peduncles. This is the crus or the peduncle of the cerebellum and then descend downward. In the most inferior caudal part of the medulla, the tract divides into 2 parts. Here this is the most caudal part of the medulla, and here these tracts divided into 2 parts. The fiber in the lateral cortical tract decussate, crossing over the other side of the CNS. The lateral tract cross or decussate to the other side. They then decussate into the spinal cord, terminating in the ventral horn at the lower segmental level. Here decussation occurs. They then descend into the spinal cord, terminating in the ventral horn at all segment level. After decussation, when they emerge from the medulla oblongata and the lower part, they decussate and then they descend through the spinal cord and they make synapse at all segment level. From the ventral horn, the lower motor neuron go on to supply the muscle of body. The anterior cortical tract remain ipsilateral, descending into the spinal cord. When emerged from the medulla oblongata, it remains ipsilaterally, and when it reach the spinal cord, it then decussate and cross to the other side. In the ventral horn of the cervical and upper length thoracic segment level, they then decussate and terminate in the ventral horn of the cervical and upper thoracic segment level. Here at the cervical and upper thoracic level, they then decussate and cross to the opposite side, and there they make synapse. In the most inferior caudal part of the medulla, the tract divides into 2 parts. The fiber within the lateral corticospinal tract decussate cross over the other side of the CNS. Function of corticospinal tract: voluntary motor control of the body and limbs. Corticospinal tract control voluntary motor movement of the body and limb. The pyramidal tract are also responsible for modulating sensory information from the body. Because most 70 to 80% of the concentration of the connection cross the midline at the level of medulla and other at the level of spinal cord, each side of the brain is responsible for controlling muscle on the opposite side of the body. After patients are lesioned in some part of the pyramidal tract, they are paralyzed on the corresponding side of the body. However, they can relearn some crude basic motions but no fine movements. This implies that the connection to these tracts are crucial for fine movement, and only partial recovery is possible if they are damaged. Corticobulbar tract. The corticobulbar tract arises from the lateral aspect of the primary motor cortex. It's the lateral aspect and it's originated from here. They receive the same input as the corticospinal tract. The fiber converge and pass through the internal capsule to brainstem. The same pathway like the corticospinal tract pass through the internal capsule. The neuron terminate on the motor nuclei of the cranial nerve in the midbrain. Synapse with lower motor neuron which carry the motor signal to the muscle of the face and neck. Clinically, it is important to understand the origination of corticobulbar fiber. Many of these fibers innervate the motor neuron bilaterally. For example, fiber from the left primary motor cortex act as upper motor neuron from the primary motor cortex act as upper motor neuron for the right and left tracheal nerve. There are a few exemptions to this rule. There are, however, 2 exemptions. Upper motor neuron for the facial nerve have a contralateral innervation. This only affects the muscle in the lower quadrant of the face below the eye. Upper motor neuron of the hypoglossal nerve only provide contralateral innervation. Extrapyramidal tract functions. The extrapyramidal tracts serve an essential function in maintaining posture and regulating involuntary motor function. In particular, the extrapyramidal tracts provide postural tone adjustment, preparation of predisposing tonic attitude per involuntary movement, preforming movement that make voluntary movement more natural and correct, control of automatic modification of tone and moment, control of the reflex that accompanying the response to affect and attenuate situation or reaction. Control of the moment originally voluntary then become automatic through exercise and learning, e.g. in writing. Inhibition of involuntary movement, hyperkinesia, which are particularly evident in extrapyramidal disease. Extrapyramidal tracts. Extrapyramidal tract. These tracts originate in the brainstem carrying motor fiber to the spinal cord. They are responsible for the voluntary and automatic control of all musculature such as muscle, tone, balance, posture, and locomotion. There are no synapses within the descending pathway. At the termination of the descending tract, the neuron synapse with a lower motor neuron. Extrapyramidal tract. The extrapyramidal tract originates in the brainstem carrying motor fiber to spinal cord. They are responsible for the involuntary and automatic control of all musculature such as muscle tone, balance, posture, and locomotion. This is the brainstem, midbrain, pons, and middle of lingutta. There are 4 tracts in total. The extrapyramidal tracts are 4 in number. The vestibulospinal, and reticulospinal tract do not decussate, providing oscillatory innervation. You can see that these 2 tracts are not decussate and they remain on the same side. The rubrospinal and tectospinal tract to decussate and therefore provide contralateral innervation. The 2 tracts then, rubrospinal and tectospinal tracts, are decussate and they control the body function on the opposite side. Vestibulospinal tract, they begin with the axon on the vestibular nuclei within the brainstem and terminate by synapsing with the interneuron present in the anterior gray column of the spinal cord. The vestibulospinal tract consists of medial vestibulospinal tract and lateral vestibulospinal tract. Each tract is responsible for increasing anti-gravity muscle tone in response to head bending tilt to one side. Anti-gravity muscle are extensor muscle in the limb. Lateral vestibular muscle originate within the brainstem. Fiber descend oscillatorily through the interior ventriculus of the same side of the spinal cord, synapsing on the exterior anti-gravity motor neuron. Origin: medial and inferior vestibular nuclei. They are located in the pons in the medulla. Course: descending bilaterally in the middle longitudinal fasciculus, synapse with the excitatory and inhibitory neuron on the cervical spine. Innervate: interneuron in the cervical and upper thoracic spine. Functions: upright posture maintenance performed by both the medial and lateral vestibulospinal tract. Upright position is maintained by both the medial and lateral vestibulospinal tract. The medial tract supply the muscle of the head and neck, where the lateral tract supply the muscle located in other part of the body. When the head of a person move, signals are sent by these vestibular tract to specific anti-gravity muscle. These muscles contract and maintain the upright posture of the body. They contract the extensor muscle and relax bladder muscles. Head and eye coordination: perform the synchronization of movement of the eye with the movement of the head so that eye do not lag behind when the head move to one side. This function is is very important for maintaining the balance of body. Head righting reflex. These are responsible for keeping the head and gaze horizontal. Eye righting reflex, vestibulo-ocular reflex. This originates in the ascending medial longitudinal fasciculus and extend to the extraocular muscle of the eye. The horizontal position of the eye when head is an upright posture set in causing by cancelling of the tonic activity of the deteriorating pathway. It is therefore able to keep the eye still while the head moves, allowing MS to focus on the retina. Pathology of vestibulospinal tract. The vestibulospinal tract can be damaged by injury or disease of the spinal cord, including ataxia. The person is unable to maintain his balance, especially when the eyes are closed. It is due to the loss of vestibulospinal reflex. Here you can see when a person closes his eye, he loses his balance and fall to the ground if there is damage to the vestibulospinal tract. Hypermetria. Ataxia in which movement overshoot the intended goal. Here you can see they may be overshoot or hyposhoot. Here in this picture you can see that person is trying to catch a ball. So in this case he is overshooting and here he is hyposhooting. Postural instability. The person is unable to maintain an upright posture. The patient will not be able to maintain posture with walking and will fall on the affected side. Damage to the medial vestibular tract will result in nystagmus, and nystagmus means fast movement of the eye either horizontally up and down or in circular fashion. The dorsal reticulospinal tract is inhibitory, medial reticulospinal and vestibulospinal tract are facilitatory. If this is impaired, it would cause further symptom of the upper motor neuron syndrome. Reticulospinal tract. Reticulospinal tract is a descending tract present in white matter of the spinal cord originating in the reticular formation, carrying information from the reticular formation in the brainstem to the peripheral body part. The reticulospinal tract is responsible primarily for locomotion and postural control. The reticulospinal tract is comprised of medial pontine tract and the lateral medullary tract. It is part of the extrapyramidal tract. In medulla they are located laterally and in the pons they are located, the reticular tracts are located medially. Medullary reticular tract arises from the nuclei of the reticular formation located in the medulla and brainstem. Medulla and brainstem they are located. Pontine reticular tract arise from those nuclei of reticular formation which are present in pons. And medullary reticular tract pontine decussate ipsilaterally in the anterior pedunculus, responsible for controlling axial and extensor motor neuron, enable extension of the leg to maintain posture support. Stimulation of midbrain locomotor center can result pattern movement, e.g. stepping. Lateral reticulospinal tract arise from the medulla or medullary. They are also called medullary tract. Descend bilaterally in lateral pedunculus, responsible for flexor motor neurons, inhibit the middle reticulospinal tract and therefore extensor motor neuron, enable modulation of the stretch reflex. Function of reticulospinal tract. Motor activity. The reticulospinal tract is one of the most important extrapyramidal tract for controlling the activity of lower motor neuron. It can influence the activity of alpha and gamma motor neuron through interneurons. The fiber of reticulospinal tract can inhibit or stimulate motor activity. Postural maintenance. The reticulospinal tract is essential for maintaining the posture of the body. Control of autonomic function, for example, heart rate, circulation, breathing, respiration rate. Control of sympathetic outflow as well as sacral parasympathetic outflow. It results in reciprocal inhibition of the flexure and extensor functions. Region of the corticospinal system can result in decreased posture control and reduce selectivity of postural control. If the excitatory fiber in the reticular formation have a lesion, this can result in hypotonia by loss of decreasing excitatory impulses to the spinal. Conversely, inhibitory fibers are disrupted in the reticular formation. This could result in hypertonia. Spasticity as the lateral reticulospinalis is involved in inhibition. If this pathway is disrupted, it can result in spasticity. Here you can see the muscles are spastic. Rubrospinal tract. The rubrospinal tract originates from the red nucleus, a midbrain nucleus. This is the midbrain nucleus. Here it originates from the red nucleus. As the fiber emerge, they decussate, crossing over the other side of the CNS and descend into the spinal cord. Thus, they have a contralateral innervation. Just after origination, they decussate and then innervate the contralateral side of the CNS. The most important function of the rubrospinal tract is the control of muscle tone and flexure muscle group, causing flexure to contract and extensor to relax and vice versa. Play an important role in flexure reflex activity. For example, withdrawing hand after touching a hard object. Flexion of limb when something hit the flexure surface. Inhibit the contraction of anti-gravity muscles. Play a role in fine control of hand movement. Region of the red nucleus can result in movement disorder and tremors. Tactospinal tract. This pathway begins in the superior colliculus of the midbrain. Colliculus is a structure that receives input from the optic nerve. The neurons then quickly decussate and enter the spinal cord. They terminate in the cervical level of the spinal cord. The tactospinal tract coordinates movement of the head in relation to vision stimuli. Thank you. Please subscribe the channel. Down the bell icon and write down your valuable comment for the improvement of the channel.